Hello, my name is Daphne Stannard. I'm the Director and Chief Nurse Researcher for the University of California Medical Center Institute for Nursing Excellence. I also serve as the Director for the UCSF JBI Center. I'm thrilled to be here to talk about quality versus evidence versus research versus innovation. That's a mouthful. Embracing all types of clinical inquiry. This is what we're going to achieve in this presentation today. I'm going to cover it rather briskly, but there will be follow-ups, resources and tools that will help reinforce this material. So this is from whence I hail, and this is the medical center, UCSF Medical Center in the heart of San Francisco. But we actually are on 4 campuses, and we have over 500 beds. And we're part of the University of California overarching system that has 10 campuses, 5 of which have medical centers. So we are part of that big system, but we are also a standalone system. And we're unique in that we're the only health sciences campus in the whole UC system. So when you come to our campus, you see a lot of lab coats. It's a lot of brisk walking and health sciences. That's pharmacy, dentistry, nursing, medicine, physical therapy. And we have 2 libraries that support our research inquiry efforts. The big UCSF Kalmanovitz library, which primarily serves the campus side, and then a smaller but fierce and ambitious Mount Zion Fishbond library that serves the medical center side. So I'm a qualitative researcher at heart, so I have to tell you a little bit about our context and sort of how this whole thing started. This whole thing started for me in that our medical center started on a magnet journey in 2009. And around the same time, but not sort of related to this, just a sort of concurrent event, was Dr. Nancy Donaldson from the School of Nursing formed a partnership with JBI to launch this UCSF JBI Center, and that happened in 2011. So the timing of it was sort of, as they all came together, was sort of around the same time. In 2012, the UCSF JBI Center moved to the medical center when I became the director of it. And so a few of you might be asking, what is Magnet? Magnet designation is the highest accolade bestowed upon medical centers and health systems by the American Nurses Credentialing Center. It's a nationally and internationally recognized designation to show exemplary patient care and nursing engagement across an organization. And there are 5 Magnet components: structural empowerment, transformational leadership, exemplary professional practice, new knowledge and innovation, and empirical quality results. The thing I want to underscore is that new knowledge and innovation is really where the research and evidence-based practice piece lies within the Magnet designation. And Magnet has been so important in transforming medical centers across the United States and abroad in terms of ensuring that there's adequate infrastructure and resources to have evidence-based practice and research activities. So it's been such a powerful and important force in transforming medical centers, and it has been a great journey for us as well. One of the cornerstones to Magnet is that the clinical nurse, the bedside clinician, what used to be called a direct care nurse, has to have empowerment, their voice has to be heard in decisions, they have to be able to make change. So we have a shared decision-making model, as all Magnet hospitals do. They all differ slightly, but so that has to be sort of in place and actively working. And you'll notice that on this slide there are a number of councils, core councils, but Research and Innovation Council is the one that really drove the new knowledge and innovation work for our Magnet journey. And that is comprised, the members of that council are comprised, the majority are clinical nurses. We have a few managers, a few clinical nurse specialists, and we have the librarians on that group as well. And then we have a lot of the clinical nurses that are there were former evidence-based practice fellows, so they've actually gone through some of these programs and they can speak to the value and the importance and what needs to be changed or what needs to be preserved. So this Research and Innovation Council did a lot of the heavy lifting during this Magnet journey in terms of identifying our gaps, what needs to be put in place, and the librarians were instrumental in that. And they, in fact, were able to turn around. If we identified that bedside nurses felt like they didn't know how to do an adequate lit search, just a really basic literature search, that came up as one of the very first things we identified. So the librarians said, well, we can offer free monthly lit searching classes. So they started putting that on, and every month those are full. We have 2,300 nurses, and they're offered monthly. They've been offered monthly since 2010, and they're full every month. So that's just, it's a really great story of the collaboration that goes on between these different disciplines to ensure that we can have the best available evidence in the hands of the clinicians. One of the Magnet requirements is that you have a graphic that speaks to your philosophy of research and innovation or new knowledge in your setting. And of course, we went to the literature and looked at what's out there, but we didn't really care for a lot of the existing models because they were primarily aimed at either just evidence-based practice or aimed at research. And we feel it takes all flavors of clinical inquiry to adequately address the complex and thorny nature of a lot of our clinical issues. So we had to come up with our own model, which is called the UCSF Clinical Inquiry Model. And there's a reason we called it the Clinical Inquiry Model and misspelled it. We do know how to spell. But we called it that because our professional practice model was the AACN Synergy Model. And clinical inquiry is one of the nurse competencies in the AACN Synergy Model. So we thought that was pretty clever to align the name of our research graphic and model to be aligned with it. So clinical inquiry is our model. And as you notice here, patient and family are the very center of the model because everything we do is about them. Even any research question you would ask, at the end of the day, in a healthcare setting, you're asking something that impacts patients and families. Even if you're asking about a staffing model, let's compare this staffing model on demonstration unit A to this staffing model on demonstration unit B, you're still, at the end of the day, looking at patient and family outcomes. So the patient and family are in the center, and then these flavors of clinical inquiry are around the side, and that's what we're going to talk about now. So quality improvement is the first sort of flavor of clinical inquiry, and it's represented as the QU in our model. And that's defined as the deliberate application or implementation of knowledge in local settings that's been previously discovered. So that's a really critical distinction. It's already been found in the literature as being effective in some other setting, or maybe in multiple settings. But you're taking that finding and you're implementing it in your local setting to see if it actually improves outcomes in your setting. You know, context and culture are important, and it may be that what worked in hospital A is not going to work in your hospital B. So you really have to do that kind of work to see if it works for you, and that's a quality improvement activity, and it's vital work. It's as important as research. It is vital work, but it's different than research. So that's why there has to be a place at the table for all types of clinical inquiry activities. This is a workflow. We developed workflows to help clinicians understand the differences between these different clinical inquiry activities. And so if you start at 12 noon and move clockwise around the circle, you'll see that it starts with the patient, family, issue, or problem. That's no surprise, right? We talked about how the patient and family is always in the middle of the model. The next step is to access the evidence, because even if you think you're the first one to have this idea and really no one else has ever had this idea, it's just crazy original, you should still go to the literature and see if anyone else has had this idea, because chances are someone's had something to say about it. It may just be a letter to the editor saying someone ought to do something about this. This is a big problem. But you should go and access the evidence and see what's out there. And then you need to appraise that evidence, because maybe there are 10,000 articles out there, but really if you sift through them, really only 3 or 4 apply to what you're actually looking at in your unit with your kind of patient population and the kind of intervention you're thinking about putting into place. So that appraisal piece is very important. And then you need to gather some baseline data, some pre-data, so to speak, because if you're going to put something in place and test the effectiveness of it, you need to be able to have baseline data against which to compare. So you gather that baseline data, you apply that intervention or the already discovered knowledge to your local setting, and then you gather post data. It sounds so simple. Of course, a rigorous quality improvement project can take a year or longer to put in place, because there are many, hopefully you have many stakeholders. It can be quite complex in terms of the design. And then of course you always want to disseminate your findings and share best practices with others. So this sounds simple, like you would do it over a weekend, but it really usually takes longer than that because there are multiple stakeholders involved. The second clinical inquiry activity is evidence-based practice at the point of care, and that's represented as the E in the clinical inquiry model. And that's defined the way many have defined in terms of the utilization of best available evidence combined with clinical expertise and patient and family values and preferences. So this is, if you think about it as a 3-legged stool, you'll understand why this is dynamic and interactive. You can't just go in saying, okay, this is the plan and this is how it's going to be, and we're not ever going to deviate from this plan. plan. That is sort of the old model of healthcare. But the fact is, if patient and families have a voice, and they should have a voice in their care, they could change their mind and say, you know, now I'm not really that comfortable with the plan. I know we talked about that at my pre-visit 6 weeks ago, but now some other things have happened. My daughter's going to graduate from school. I really want to be there, so I don't want this procedure to interfere with that. I need to be there. So there may be some changes that happen. Along the way, of course, science doesn't sleep, so there may be new available evidence that wasn't there 6 weeks ago when this plan was made. And additionally, the clinicians may have had some changes in heart in terms of what their judgment is telling them is the best plan for this particular patient and family. So all of these moving pieces need to, it's about being adaptive, and you need to think about zigging and zagging, so to speak, on the fly all the time when it comes to evidence-based practice. And all clinicians are doing this every day. It needs to be a vital piece of their practice. This is the workflow for that. The patient-family issue problem starts it, but then accessing the evidence, appraising the evidence, and then using the evidence, because you know you want to use best available evidence to help guide your practice. The R is research in the clinical inquiry model, and that's a systematic process that's discovery-oriented. So that's really juxtaposed against quality improvement activities, because if you recall, the quality improvement is about taking something that was previously discovered and implementing it in your local setting. Research, you embark upon this activity if there has not been anything in this area that's really truly discovering something new. It can take different forms depending on the discipline and the research questions. So, you know, historical research is very different from someone who's in cinema studies. That kind of research is very different. So the nature of our discipline changes how we take up research. But in healthcare, primarily there are two major ways to go about it. There's the primary research or secondary research. So primary research is a systematic investigation to develop or contribute to generalizable knowledge. We always want to share what we've come up with, what we've discovered. This can be quantitative, can be qualitative, or it can be mixed method. And always the plan is to publish that to the greater community. But because we deal with organic human beings or their derivatives like cell lines and tissue types, most primary research has to go through a human subject or animal subject IRB process for approval. So institutional review boards are involved, which always makes primary research just a little bit more complicated. You'll see here on this workflow, again, the same part of the workflow is the same. The patient-family issue or problem drives you going to the evidence, and you need to appraise that evidence. But now you need to obtain IRB approval. Even if you're doing it on dogs, as in a wet lab, before it even gets to humans, there are animal IRB processes that you need to go through. Then you gather your baseline, test your new knowledge, and gather your intervention post-data. Now, of course, I'm simplifying. There are many, many complicated crossover research designs, but for the sake of a workflow, it's a similar kind of workflow. You have to gather something beforehand, that you have something against which to understand the results on the back end. The pre-data in primary research can often look very different, but that's essentially the goal. Secondary research is distinguished from primary research because this is where you're dealing with a pre-existing data set. So it involves a summary and analysis or synthesis of existing research. So with a secondary analysis, this is where I may take someone else's data set, with their permission of course, and ask a new question of it. So maybe it was collected for question Y, but I'm coming in with question Z, and I can use this existing data set to answer that question. So in that way, it's like a new set of lenses. You're asking a new question, you're putting on new glasses to ask a new question off of an existing data set. A systematic review is another form of secondary research because you're gathering the data that is out there in the form of published articles, even in the gray literature, and you're pooling it together and making a statement, recommendations. You're contributing to science as a result of what's already out there in the literature and pooling it together. But because in both cases no human subject content is necessary, no IRB approval is necessary. So I want to take just a sideline here to talk just a little moment about what a systematic review is. It's the identifying, selecting, and appraising, and then summarizing primary or single studies addressing a focused clinical question. They're extremely rigorous. If you go through what I call a formal systematic review, it's an incredibly rigorous process. And the whole point is to reduce the likelihood of bias, because you don't want to have either poor quality research pulled into it in the first instance, or go about it in a sloppy, haphazard manner such that you come up with recommendations on the back end that aren't supported by the extant literature. So it is a form of research in its own right, and it's often called secondary research. These are two clinicians that are actually engaged in a systematic review process at this moment from UCSF. The only reason I'm doing a call out to them is because they come from two different systems, and they came together for the sake of doing the systematic review. And so that's really lovely. It's like any other research team where you can pull people together from all over the world to do your research. And the same thing can be done with systematic reviews. And it can be very powerful because presumably once they find whatever they find in the systematic review, we can make changes at two health systems, not just one, right? I mean, and of course it'll be published, so then we can make changes in many, many other settings. So a systematic review is contrasted to a literature review because a literature review, as many of you remember, is sort of what we used to that's what we used to call. A narrative review is another term that's sometimes used, but that's where an author would go and pull articles and summarize them. But often would pull the articles that supported their position. I mean, it would rarely be systematic in terms of the culling of the literature, nor would it be systematic in terms of how they were analyzed and summarized. So it often became sort of opinion pieces in terms of, look at these 16 articles that I found that support my position. So there's little or no attempt to be systematic in the way the questions were addressed, the search and selection for the evidence, the assessment of the quality of the studies, and the summary of the results of these studies. So these narrative reviews or literature reviews are prone to bias and error. The little cartoon at the bottom is a kitchen table, because in the old days we used to just, and I am old, we used to just pull together articles and spread them out over our kitchen table, and this is how science was born, right? I mean, this is where we would do our lit review. But there was no structure and there were no formal rules, so it really could be just Daphne's position on this, and I'd pull out the articles that I felt were best suited my position, and I would just leave the others behind because there were no rules saying I couldn't do that, and I could write very persuasive lit reviews. The problem with that, of course, is it's nowhere close to truth, and some would argue there is no such thing as truth, but having said that's a different topic altogether. But it's nowhere approaching that because it really is supporting just one person's opinion. And of course, I just want to remind people, though, that going through a formal systematic, let me back up, not doing a formal systematic review, going a lit review and just saying colon, a systematic review, that doesn't change anything. That just means you've changed your title. But a formal systematic review really has a set of rules and has a procedure attendant to it. And so that really does differ from the traditional narrative or lit review, which is why systematic reviews are on the top of the level of evidence pyramid now. Used to be randomized controlled trials were considered the gold standard, but systematic reviews can be more powerful because they can pool randomized controlled trials. So they're even higher on the food pyramid, or evidence pyramid. It is sort of a food pyramid too. And you'll see that all of you are familiar, I think, with these evidence pyramids, that the lowest level of evidence, there's more of it at the bottom, and that sort of bubbles up as there's more science and there's more rigor over the research design to get to the very top, which would be then the randomized controlled trials and then ultimately the systematic reviews. So the workflow for secondary research is you start with your patient, family, issue, or problem at 12 noon, then move down again, accessing the evidence, appraising the evidence, systematically analyze your already collected data, and disseminate your findings. It makes it look so simple, and truthfully, secondary research is as complicated as primary, but for the fact that you don't have to go to the IRB for approval. Innovation is the I in clinical inquiry, and innovation means new, but new is not always better. So for that reason, innovation always has to be paired with quality improvement activities or research, depending on the question and the innovation, so that whatever you adopt, you can say that it has been tested and has been proven to be successful in your setting. So that means, again, collection of pre and post data. And this is my daughter's wrist, cute wrist, don't you think? And we actually, when we were going on our Magnet journey, we found that this was a problem in our setting, because especially with innovation, I think UCSF is not unique in this way. Medical centers are busy places, little time to sit back and smell the roses. So people have a problem and they just go and solve it. They say, look, I went to the literature, they say this kind of mattress is effective in reducing pressure ulcers, let's get it and let's see if it helps. So maybe they weren't disciplined at doing pre-data collection to sort of show the scope of their issue. They put a mattress in place, and maybe they do a little post-intervention data collection, but maybe it wasn't even aligned with what they were looking at on the pre-side. So that was messy, and that was something that we decided we had to clean up on our medical center side to be successful in this clinical inquiry journey. And so the chief nursing officer and I joked about maybe tattooing pre and post on every new hire's wrist. We ultimately decided not to do that. But I did get temporary tattoos just because at that point I thought it was funny. So it is a common theme. Pre and post is important sort of for every flavor of clinical inquiry. So this is the innovation workflow. Patient, issue, family starts it, accessing your evidence, appraising the evidence. You may need to consider IRB approval. Even quality improvement studies may need IRB approval if you're dealing with a vulnerable population. Not the norm, but it could be the case. But clearly with research you would need to get IRB approval. Then gathering your baseline data, apply that innovation, and then test it and gather your post data. So why does any of this matter? Why are we even doing any of this? Well, in part we're doing it because we are told we need to do it by these regulatory and quality data bodies. And so this is just a little sliver of quality and regulatory groups that we report out to, our medical center reports out to on a monthly or quarterly basis. And your hospitals are doing the same thing. And there are many others that just didn't fit on the slide. Healthcare is almost as regulated as the nuclear industry. We are very, very regulated. Now, I don't see that as a bad thing. I think regulation actually is a good thing because the regulators, for the most part, are asking you to follow best practice. They're saying follow what's reasonable and what we know to be true at this moment. It may change tomorrow, but at this moment, what we know to be true that would help enhance patient and family outcomes with subject A or population B. So following these regulatory guidelines really should be something we all are happy to do. It does require infrastructure. It requires a strong quality department to track all of this. And I think for clinicians, the most important thing is to remember that this is really about putting a face on quality, because some of these audits can be tedious. Really, do I have to collect another blood audit for the FDA? Well, yes, you do. And the reason we need to do that is because it's ensuring that we're doing the best patient and family care possible, that the processes are in place to ensure that the right blood goes to the right patient or whatever the issue is at hand. And I think JBI, or Joanna Briggs Institute, can help because it puts the best available evidence at the clinician's fingertips. So that's where I'm going now, is to talk a little bit about JBI. JBI has been a research institute since 1996, born out of the Royal Adelaide Hospital and now at the University of Adelaide. It's a not-for-profit organization with over 75 centers and groups, over 7,000 members in over 47 countries. These are some snapshots I took last time I was in Adelaide. It's a beautiful city. I highly recommend you go if you've not been already. That one at the bottom, that little blob in the tree, that really is a koala bear. They really do exist in Australia. They're darling little beasts. And JBI has a beautiful new center in a lovely, lovely university setting. You can see here that all of the areas on this globe that are blue are areas that have a JBI presence of some sort, a center, several centers. So you can see that there's a wide coverage globally, which is part of what makes the collaboration so special and makes it so strong. So now, JBI is not the only sort of online database of systematic reviews. Of course, many are aware of Cochrane. Cochrane collaboration comes out of Oxford, and they really are about quantitative health science reviews with a strong biomedical bent. Campbell collaboration out of Norway focuses on quantitative social science reviews, and then JBI out of Adelaide, Australia, really focuses on qualitative and quantitative health science reviews. And I want to pause for a moment and just give a little nod to Dr. Alan Pearson, who was the executive founding director of JBI. He once told me, proudly that JBI is known for their pluralistic vision of evidence, and it is so true, and that's one of the things I find so pleasing about working with JBI. Not only does it have a space at the table for qualitative and quantitative, which is unusual in and of itself, but it also, JBI accommodates all levels of evidence for a systematic review. You can do a systematic review looking at just text and opinion papers because maybe there is no research evidence yet on that subject. And that's so powerful because in healthcare, there are many emerging and evolving conditions, like say MERS is topical right at the moment, that are sort of moving quickly, and we may not have science on it yet, but yet we still may need to do something in healthcare to address that issue. So there, in fact, we can do a systematic review through JBI looking at sort of lower forms of evidence because that's the best available evidence we have in the moment. So this is the JBI model, and pleases me very much. It's a great model. You'll see evidence-based practices in the center of the model, which, if you recall, is the three-legged stool, so evidence, context, and client preference or judgment. But the mission of JBI is to promote and improve global health. So that starts with healthcare evidence generation, which is that sort of purple quadrant. And that is about primary research. And JBI really, they have their finger in many things, but that's the one that they sort of don't have their finger in. They really do rely on primary research to be generated around the globe. But once that primary research is generated, that's when JBI can spring into action with the green quadrant, because that's when evidence can be synthesized. So that's when people who have been trained to do comprehensive systematic reviews can go and do systematic reviews on that primary research that's been generated. But that alone is not sufficient. JBI, remember, is about improving global health. So that means it has to get, that information from that systematic review has to get in the hands of clinicians in order to make a difference. It's not just an academic exercise where you put the systematic review on a shelf and say, great, I'm glad I did that, now I can move on with my life. That's not the point. The point is that it now needs to go into the clinician's hands, which is the evidence transfer piece in blue, and then it needs to actually be used to change practice, and that's the red piece. So that's so important to actually make a difference. It means all of those pieces need to be in place. So the last part of my presentation, I'm going to talk about the 5 steps of evidence-based practice, but I'm going to showcase JBI product that really hit upon these points. Many of you know these 5 steps, so it's really not about the 5 steps as much as the structure to sort of showcase some of the JBI resources that I think are available that would help you actualize evidence-based practice in your setting. So identifying the problem is the first step to the 5 steps to evidence-based practice. And many of you know the PICO format to questioning. But most of you, I think, know the population intervention comparison or comparator and outcome format. And that's really for a quantitative question or a review of effects and economics. But if you were to go about asking a qualitative question or something that would involve textual data, then you couldn't use that same, it wouldn't be right to use the same PICO format with a comparator, for instance. That just isn't how qualitative design is set up. So instead you would use PICO still, but now the PICO mean different things. P still stands for population, but the I now is for phenomenon of interest, and then the CO is for context. So that's a really great tool that JBI has built into their systematic review summary software suite, such that you can ask both qualitative and quantitative questions. Again, sort of getting to that pluralistic vision of evidence that's so important. Accessing the evidence is the second step of 5 steps to evidence-based practice. And I would say accessing, the most important thing, if you have JBI access at your facility, make sure it is available to clinicians. Just having it on a library website buried deep among many other databases, a busy clinician is not going to take time to sift through all of those different web links to find it. They're just not. So we do have it on our main library website, but we know that it gets very little traffic there. We actually monitor it, and we know this is not how most clinicians are getting to it. The main library web page have nursing subject guides. So this is a nursing subject guide page for nursing. And then we have, that's from our main library. Then we also have a subject guide for nursing out of the Mount Zion Fishpond Library. This one has the link to JBI right there on the front page. But what really gets us traffic is having it here on this main web page, which is the default web page on all of our computers throughout the medical center, in the clinics, the ambulatory areas, in the main hospital, in all all of our 4 campuses. This is the default screen that the computers just go to, and this is just really a web page full of links. But you'll see in the blue section under healthcare information, in the very top section, clinical references, JBI is right there near the bottom, and all clinicians know about it. They go to it, even if they don't know what it is. Maybe they're just curious. They go and click on it, right? But we get a lot of traffic, and in fact, we know that people are using it. I've got a slide coming up to show you that people are using it. Appraising the evidence is the third step to the 5 steps to evidence-based practice. And JBI has training worldwide to teach users how to become facile with comprehensive systematic reviews and to use their software and tools. One of the tools they have built into their software are these critical appraisal tools. And they have different tools based on the research design. So it's again contextual, and that's good. The RCT quasi-experimental studies, for instance, that appraisal tool is based off of the consort guidelines, which, as you know, are the internationally reported guidelines for RCTs. All of their critical appraisal tools are based off of international reporting guidelines, but for qualitative, because qualitative researchers can't decide. We can't agree. So we do not have international reporting guidelines for qualitative design. So that one is really just a critical appraisal tool that was designed by JBI staff and experts based upon best practices around appraising qualitative research. And this is just a flyer from our center to show that these training sessions are frequent. They're held worldwide. Centers all over the globe teach users how to use the JBI software and how to actually go about doing a systematic review. So if any of you are interested, I strongly encourage you to go on the JBI website. The training dates are there, I think, globally. So you can reach out to a center that's closest to you and attend one of these week-long, really rigorous and great workshops. The fourth step of evidence-based practice is actually using the evidence. So this is a clinician from UCSF Medical Center, Oliver Tremblay, and this is a real nurse in real patient care. This was actually not a stage photo, and he'll be embarrassed that I say he's photogenic, but he is very photogenic. I just happened to walk onto this ward because I was early for a meeting, and the conference was the meeting I was going to was in a conference room down the hall, but I was there uncharacteristically early. So I said, I'm just going to go check out the ward. So I just walked around the corner and just walked up and down the hallway, and I saw him in a patient's room. I didn't know him. He's just a nurse working on a computer, but I saw a JBI product on the screen. I'm like, wow. So I walk in there and I say, can I take your photo? And he's like, yeah, I get. And there's a patient in the bed. I'm sure the patient thought that was a little peculiar or whatever. So I took his photo, and then I said, what are you doing with this thing that's up on the screen? What is this about? And he said, well, I've been newly appointed to the Pressure Ulcer Prevention Committee for my unit, and I heard JBI had some good resources on that, so I'm going here to check them out. Oh my gosh, I was so happy to hear that. So he in fact was looking at a best practice information sheet, which is one of the tie-in products that JBI staff and the authors of these systematic reviews create. They're based off of a systematic review. So a systematic review can be 100+ pages, right, with all the evidence tables and all of the information that goes into it. A busy clinician probably is not going to read that on their lunch break, right? They're not going to say, hey, I'm interested in pressure ulcer prevention. I think I'm just going to, in my 10 minutes of lunch, read this systematic review. But they might read the best practice information sheet because it's 4 pages long and it's bigger font and it cuts to the chase. It talks a little bit about how the systematic review was conducted, who was the population. It talks about that, but then it tells you the bottom line recommendations. And in this particular question, this is what you need to do to prevent pressure ulcers based off of the systematic review. So that is really a beautiful piece of evidence that clinicians can use at the point of care every day. Now, we don't have them for every clinical problem. That's because we do more systematic reviews on every clinical problem. So these are tie-in products based off of existing systematic reviews. So if you go onto JBI and you see something there's a gap, that just means that systematic review needs to be written. So that's something that we all need to hear so that we can all work on that systematic review together. But the best practice information sheets are really, truly beautiful, and clinicians use them and should use them more often. The fifth step is evaluating the practice change. If in fact a change was made based upon evidence, then how to evaluate that the change was effective and it sort of has traction and lives. This is off of the Ovid. When you go to more EBP tools and you click on that, you'll get this screen. I want to sort of focus on the red section that says quality improvement and draw your attention to JBI PACES at the very top. Again, time doesn't allow me to go over all of the other JBI product, but I really believe PACES is important and I want to underscore it. So PACES is is a tool that enables clinicians to do audits and to track them more easily. It's mobile friendly, so this can be on iPads. We did some of our PACES data collection off of iPads. I haven't tried it on a phone. It's a pretty small screen, but I presume it would work. And of course, it can be done just on any computer. So if you see here at the very top under audit, it talks about what this particular audit was done on early rheumatoid arthritis management. And if you look under cycle, it says it's a baseline cycle. So this is their pre-data collection. And this team went and they used these audit criteria and they said yes or no, yes it's present, no it's not, or not applicable. If they set up their design such that they knew number 3, the criteria 3 never applied in their population, you can do an NA. So they collect their pre-data. In my pre-data, you'll see at the very top there are tabs. There's compliance report, then there's GRIP project team. So GRIP is a piece that sort of is sandwiched. You collect your pre-data, then you do GRIP, and then you collect your post-data. GRIP is getting research into practice, and that's a piece of the program that lets you lay out who your stakeholders are, what you anticipate to be some of the obstacles or challenges, what your intervention is, and who you're going to bring in to help you do that. And so it pulls together sort of your project planning or your project management, and then you have really a sort of a nice executive summary that you can print out and send on to your executive stakeholders who are saying, when is that report? I need it now. What are the answers? You can send that to them saying, we're working on it. We've got a multidisciplinary group together, we've had our first meeting, we've got a plan, and we're going to do this intervention, and we think that will improve our audit results. This is a nurse, Amy Dunn, who was collecting data for a large multi-center PACES project out of JBI, and we wanted to be involved because we wanted to get our feet wet with PACES, and it was a really positive experience for us. And so she actually did most of her data entry through iPads, but in this particular case it was a bad photo. This was a stage photo, and I made her stand by a regular computer for this. This is just showing you, now you've done some post-data collection. So the gold bar shows you your pre, okay, you're hanging in the 40s, and the criteria 4, you're down at 25%, boo. But then they put some intervention in place. If we look to the GRIP project team and we looked at that GRIP thing, we could find out what they did. But I don't have access to that. But we can see that their post data, they're up to 100% compliance on all criteria. Amazing. So it just, again, helps you to audit and keep track of it. And they have these these reports are easy to generate and send out to your stakeholders. So it's a really nice user-friendly product that's helpful in healthcare. The Clinical Fellows Program is a short program offered by the Joanna Briggs Institute, and I believe Singapore and now the San Francisco Center are other centers that offer this program. We'll be starting our first Clinical Fellows Program in September. And this is really to train people on PACES and to train them how to do a rapid cycle small test of change using PACES to track put an intervention in place, gather the post, and sort of continue until you have traction to solve your issue. So to summarize, there are many JBI resources available to you, the subscriber. The systematic reviews, they're a suite of software tools that enable one to do the systematic reviews, but then the systematic reviews that have been completed are there in their online library. The best practice information sheets, I did a little call out to that earlier. Those are those 4-page, easy to read, tie-in products that really are linked to a systematic review. They are based upon a systematic review. So they're just terrific. They're sort of pre-appraised, highest level of literature evidence for you to go to as a clinician. There are evidence summaries, and I haven't dwelled on that really, but this is often used by the nodes. Nodes are groups of people that have like interests. So I'm actually a co-chair of the Surgical Services Node, and Drew Riddle out of Texas Christian University is the other co-chair. And we look at the evidence summaries within the Surgical Services Node to see which of those really that we need to sort of do systematic reviews, because there's a gap, there's a serious gap there. Maybe what we have is the evidence summary that is sort of a stopgap measure until we can have that systematic review done. But evidence summaries are often created by JBI staff and other collaboration members that are experts in their field to help put something in place when members cry out for it. So for instance, one evidence summary was just created on surgical site infections. But clearly, a systematic review needs to be done in that area because that is lacking, and we know it's a big issue. So there is an evidence summary for that. until we can get that systematic review done. There are recommended practice sheets and also consumer information sheets, and they are valuable as well. Time doesn't allow me to go into those, but those are also other resources that JBI has for clinicians and patients and families. So I need to tell you the end of the story. You can't start a story and not tell the end. So the end of the story is that the UCSF Medical Center did achieve ANCC Magnet designation in 2012, and the appraisers were very impressed with the spirit of clinical inquiry when they, of course, we had a good document or they wouldn't have come out to do their site visit, but then when they came out to do the site visit, that's when the rubber meets the road, right? That's when they talk to clinicians in an unfiltered way. You don't know what they're going to ask. You don't know how to prepare your clinicians. We have 2,300 nurses. We couldn't have prepared them all to answer whatever the appraisers wanted to hear. So they just went around and talked with groups of nurses, went up to the units and asked them questions about clinical inquiry along with other things, right? That wasn't just it, but the piece that I was most concerned about, because that was my area, was this new knowledge and innovation. And the appraisers said that they really were impressed that there was such a strong spirit of clinical inquiry at the medical center. And I don't think it's just due to the JBI Center, although I certainly don't think the JBI Center heard. That we had a strong emphasis on evidence-based practice and sort of what that meant and what JBI meant at the same time that we were preparing this Magnet report. So there was a lovely synergy between the two. And the appraisers had made comment that they had never been to a hospital that was also a JBI Center, and they really felt like that was impactful in this way. So that it was a special time. We are still on the Magnet journey because, of course, now it's time for us to redesignate. So we're alive and well in terms of keeping our research inquiry alive, keeping our other activities, our other clinical inquiry activities going. Our JBI Center is thriving, and I just want to do a little call out. It's the clinicians, of course, who help make it a thriving center, but our medical librarians have been such partners in this journey as well. One of the things that we underscore in training, and I think any CSR training, it's underscored, that in order to do a systematic review, you have to have methodological and content expertise. You shouldn't go into a quantitative systematic review knowing nothing about statistics. That would be scary. You shouldn't do that. Likewise, you shouldn't go into a qualitative systematic review knowing nothing about qualitative philosophy, paradigms, and sort of worldview approaches with the data. So having said that, if you're doing a quantitative systematic review, we always encourage you to link up with a biostatistician, and they serve as an associate reviewer for that systematic review. Well, and to that same end, the medical librarians that help us do our lit searches to prepare us for these systematic reviews, they're also serving as associate reviewers. I mean, it takes a village to do these clinical inquiry activities. Just as you would with primary research, you'd form a big team to help you do this. The same is true with all of the other clinical inquiry flavors. It really is a team sport. There's really no clinical inquiry activity I can think of that is a solo activity. Really, everything requires a team and should require a team. Qualitative, you need to have someone else to throw your results off of and sort of sound check for validation. Quantitative, I mean, unless you're a doctoral student and you're doing all your data collection and everything all by yourself because that's part of your project, okay, maybe that's the solo sport. But even still, it's not solo because you've got your committee that's there looking at your research data and helping guide you. So really, even if you look at quality, evidence-based practice, research, and innovation, none of those are really a solo activity. They always require others. And it's important to bring the whole team together and give credit where credit is due for the work that they're doing. So I just want to call out that the medical librarians were instrumental in our story, in our particular story. So thank you so much, and feel free to reach me or reach out to Ovid and reach out to JBI if you have any further questions. Thank you.